Welcome to Nashville. How many of you are from this great state? Wonderful. I live up the road in Silver Point. 9 months of the year I'm in Taiwan, where I am teaching rehabilitation practice to physicians, physical therapists, occupational therapists, program managers, health policy makers. Taiwan has a health policy program that everybody in the country participates in, including vision and dental. It's a health destination, and it's not perfect, but it has multiple systems, thank you. It has both Chinese medicine and Western medicine. So for somebody who, like me, has been working in the Western medicine side of the world for the last 35 years, it is an amazing opportunity to learn about chronic pain and the intersection with the healthcare system from another culture. And I'm very appreciative to have that opportunity. At the same time, I am a care partner to my son who lives in Silver Point, who is 34 years old, and at 15 had a spondylolisthesis that broke. So Vanderbilt has been his care system. We are headed into our 4th spinal fusion. I know who you are and where you live because I live there too. And it has been a schoolhouse for me. My son has been a schoolhouse. I have been in the field of rehabilitation since 1972. And I, in a million years, never imagined that I would need my level of knowledge. So I have learned from not only my family, but the consumers that I work with on a regular basis. And people like me can't learn without people like you. So I appreciate your being here and making a commitment to this conversation. So I want to share with you a conversation that I think is necessary. It's not an easy conversation, but the world is changing. And you know that your world is changing rapidly. The healthcare system right now is in chaos. We've just had an election. We're seeing state pain laws passed that are different from state to state. Different people are affected. We're seeing health insurance practices and policies change. In Tennessee, we are not a Medicaid expansion state, and we are losing our healthcare insurance providers. So in Tennessee, we will have large portions of the state that will not have a health insurance provider. So that is a crisis of care that we are experiencing right here. And because of all of that, and because I do so much patient advocacy, I listen to the experience across the country. And I follow people with all kinds of issues in all kinds of places. That led me to the fungal meningitis outbreak, which has really allowed me yet another schoolhouse for the last 4-year period where 13,000 people from across the country were affected by contaminated, compounded drugs. And of some of you in this room may have had that exposure. Quite a number of people with CRPS were exposed to those injections. Of that group, we know that about 800 were identified. We know many more exist that were not identified. And nearly 80 people, a little more than 80 people died and are still in grave states of illness and can expect that, you know, they will die from their injury. So that has, not to depress you because life is, you know, sometimes a challenge. It also provided an enormous opportunity to me to look very closely at what is happening to the chronic pain experience in this country, how it's variable from state to state and practitioner to practitioner, physician orientation, and so I listened to the chatter. There are a lot of chirping birds. Patients are concerned about the status of their daily interactions with the system at this point. And there's not enough good change happening in the right direction right now. So I wanted to get to a problem that I observe that I hope will be helpful, and that is how we talk about this collaboration between physicians and the healthcare system and patients and their families. I think we have time now, we have a need for different learning. And I think that the tools that we have employed in healthcare are reactive, and they worked for a different set of structures than the ones we are facing for our future. So I want to talk about what I observe in working with consumers and their families and physicians, because I do a lot of interaction with physicians. And it's, like I said, it's not an easy conversation, but I've learned to never sell the listener short, because you are smart people. And the question is, how do we get everybody talking in the same direction? So I want to address that. I want to start by talking about obstacles and barriers to care. How many of you been to the physician in the last month? How many of you would grade that as a successful exchange? Okay. So the majority who have been to the physician in the last month would not grade it as a successful experience. Is that right? Raise your hand. Okay. I think there are 4 areas that we need to be concerned about. And I want to say that I don't think there are any bad guys in this system. I think if you follow me on Twitter already, you know that I get irritated with some things. And I hope I have some Twitter partners in this room, because you're important and you teach me. But I want to talk about the characteristics of the system of care, which are changing rapidly. They have changed on the dime in the last 2 years with state paying laws and changes in our healthcare and insurance and policy systems. We also have human factors to consider. And these human factors tend to paint a very negative position for patients who don't have the same secret set of keys that insurance companies have and physicians and policymakers have. So we want to talk about that today. I also want to talk about cognitive errors, how we think about this whole experience of pain, because it directs the language system that we use when we present to the physician, or for the physician who is operating with their own language system, who is trying to extract the elements of the story that we tell them. And they're comparing it to what the research says about what they're hearing. That is a very important intersection for us, and we need to talk about that. And then I want to talk about expectations for outcomes. Now, because we are humans, we are bound by a particular language system. The key word here is we live in a system. We aren't data. We aren't research subjects. We aren't the files that are in the computer systems of the EHR. Okay? Because we live in a system, I want us to think about how that system is operating for us. And I hope that you have questions that we can talk about by the end of the day, because these are, I think, important questions that will affect the work we do with the system in the future. This is, I don't have a clicker, but if I had a clicker, I would be pointing to this thing right here that's all those pretty colors and dots. We know that systems are independent and interdependent parts. The state of Tennessee is a system, Georgia's a system, Alabama, the nation is a system. They are resourced differently. They are organized with different partners to the chronic pain discussion. They all work with a number of variables and policy differences that affect each of these systems differently, okay? So when we're in social media and we're at Facebook and we're comparing notes, or we're in Twitter, or we're in one of our pain groups, we are very frustrated by the different experiences of people in different locations. A little closer to the microphone? Okay, all right. So I'm not really good at this. In Taiwan, they really like these things. I kind of reject them, so I'm going to do my best. In any case, these things have consequences at multiple levels. Where you enter the system makes a big difference in how you get served. How you tell your story when you enter the system makes a huge difference in how you get served. Your personal characteristics when you enter the system have a huge impact on how you get served. I have lots of personal stories. I will save them for later in the day, but I want you to keep that in mind, because this is a very important part of the problem that we see in collaboration. Right now, we're in a rapid response mode to the addiction crisis nationwide. How many of you in this room are addicted? How many of you in this room are addicted? Most people with chronic pain will recoil with being characterized as addicted. But it is part of the language system right now that is visited upon this population, and it's very hard for you to fight individually. Systems, however, are driven to self-organize, and because systems are resourced with limited resources, it tends to be the squeaky wheel that gets the worm. So right now, the public conversation is caught up in the whole issue of the addiction crisis, which is a very legitimate problem. Nobody in this room doubts that that's a very large problem. It is consuming people's attention. And the more we attend to adapt to that problem, the more we have unintended consequences in other parts of the system. And some of you are affected by that, some positively and some negatively. What we are seeing here is that in Tennessee, for instance, our primary care providers are dropping patients with chronic pain. Absolutely. Yes, I hear a yes. This could be church. All right? If you're a rural Tennessean, you've also lost your hospital in this system. If you've lost your primary care provider and you've lost your hospital, raise your hand. Okay, same in Alabama? All right, well, that goes to this whole issue of organizational structures, which are operating within a system where, as we tighten one set of screws, we're creating binding and stopping points in the system for other essential health services. We're also creating a preoccupation with a language system that is not recognizing that there are other people here to care about. So that's a very big issue for us. From that language system and the noise in the news and the addiction deaths that are published in the obituary section on a daily basis, we develop what are called mental models. And those mental models not only go to how we see ourselves as consumers, how physicians deliver services, how policymakers design policy, and how the public at large perceives the problem of care for people with chronic health care needs. Very big issue. This is an example of kind of a quick and dirty example of our healthcare system, and some of you are going to recognize yourselves in the pieces and parts here. We have patients and family members. First of all, I want to characterize a system in my context as community, and that community is inclusive of whatever your network that you rely on. It could be your state, your county. We're from the South, so we talk a lot about counties, right? The city, your church, all the things that you interact with on a daily basis for your services. Some of you may have seen that some parts of this system now are interfered with, and they're not working as well as they need to. So if you've lost your physician and you've lost your hospital, that's a significant part of your community support that's injured. And there's two really great concepts that I think are very important for us to understand, because we don't understand why things are damaged and we don't understand why it's getting better. But for those of you who like systems theory, and I never sell anybody short, I want to introduce two concepts. One is chaos. Has anybody heard of chaos theory? Okay. Well, we tend to think about it in terms of systems of manufacturing, but it's also a very important concept for social research and healthcare. And there's something called course damping. And we're going to talk about it through the day. Chaos theory is focusing on two ideas. Synchronicity, that is the way things line up in a system. And process, what happens in the process of interacting with healthcare. The other one is complexity. Our systems are becoming incredibly complex. And the changes from state law to state boards of medicine to, every time you turn around, somebody's proposing a new guideline, which makes everybody crazy. That adds to complexity. Complexity rules structures, okay? So every time we add something to this mix, our structures become more complex to manage. And the more we add to it without understanding that we're adding things, but we're not taking things away, and we're not paying attention to processes by which people interact with their system, we're creating a chaotic environment for all consumers who require health care. Humans, human factors. We all have a different pain experience. Some of you have had to deal with pain since you were very young people. Some of you came to the pain experience after leading rich lives as productive employees for yourself or somebody else, and suddenly your life stopped due to an accident or an illness or an injury. So nobody's pain experience is quite exactly the same as the other. And depending on where you are in your relationship to your system and how you as a consumer are wired to interact with this system, there are two ways of thinking that we need to be aware of, because they control your story. The story that you tell your care partners, the story that you tell your physicians and your healthcare provider in the ER. They're very much based on how you think about what has happened to you. Okay? So physicians have the same issue. They are bound by what they've learned and how they think about what they've learned. So we're going to talk about thinking fast and thinking slow, because some of us rely on fast thinking. It's based on a survival mode, and others are more reflective thinkers, where we may delay what we're doing long past the time we need to go get help, okay? That's very important. We look at system 1 here as the fast thinking system. It is based on survival skills. It's when you recognize you've got acute pain, you recognize fight or flight, you know you're in trouble, you may not have the resources you need at home, your family may not have the resources, you may need to go to the ER. So you go to the ER and you tell them your story and they don't respond. Had that experience? Okay. The people in the ER are wired on system 2. Their job is built around system 2 thinking structures, which are reflective. Okay? And they are, their job is to assess the difficult cases that come into the ER and to get them to a position of stability and then to turn them back to their provider as quickly as possible. So often as consumers, we have a clash of expectations that are very important for us because we are so frustrated by this. And that we are guided, again, by our own perception of what is happening in our own system of experience. Something gets tightened up here, it goes a little wacky over here. Pain laws are adjusted, the ER posts the sign that, no more opiates are allotted for you, and, where do you go with that? Well, something gives in your family or your system of care. You might not want to talk about it, but something's going to give. And we're seeing what gives play out on the front pages of the newspapers in some communities on a regular basis. So when we are working with our system 1 thinking strategies, we are working off of immediate survival perspectives. Our brains are wired for something called heuristics. That's one of my favorite words. But a heuristic is essentially a filter. It is a cognitive filter. It is based on prior learning. It is a survival mechanism. It allows us to make a snap judgment about our situation or the situation of somebody that we are a care partner to. All right? It depends heavily on prior learning, and it depends what we learn about in the system. There are also things called biases and fallacies. Our healthcare system is built on biases and fallacies. Right now we have legislative members that are passing laws like biscuits baking in, the oven because they're operating with the noise in the news and the crickets on their shoulder. Okay? They may not be in any position to get to that reflective thinking because they don't have your experience. Okay? That's very important for us to understand. So here's the patient in the middle of all of these people in the community that are charged to provide care. We have mental shortcuts that we use. Every person in that group will employ a mental shortcut, depending on what their job is in the system. Now, in other places in the world, we call this stovepipes of care. The biggest problem we have in healthcare right now is that nobody's talking to each other. Our system is built so that people don't talk to each other. Our EHRs don't transfer information properly. The logic in the EHRs does not collect information properly. And when we report information from the EHR system, we're reporting ICD-10 and billing codes. Well, if it's not collected properly, it's not right for the receiver. And depending on how you tell your story, you may not tell your story in a way that your listener can capture it in the system of care that they're responsible for. So I hear over and over again about how the person presents to the doctor. They go on at length to tell their story, and none of that is in their medical records. And I'm sure you've had that experience. Our medical records are not capturing that data. If we don't capture that data, we can't do anything with that data. We can't report it, we can't move the systems. It's a stopping point for us, okay? A heuristic is something that we believe that is true. It's generally true, even if it's not always true. And from these heuristics, whether you are a consumer, or you are a physician, or you are a care partner, you have things that you believe are true, even if they're not always true. Rules of thumb. And from them, we construct mental models. Now, in the medical world, we rely on algorithms. And those algorithms conceptualize a theory of a diagnosis, they capture it in the EHR, and they collect data against that logic model that is constructed in the EHR. You are the consumer. You know your problem. You know that if this happens, then this is going to happen too. Okay? Your algorithm may not intersect with your physician's algorithm. I'll tell you why. Because the information about your algorithm hasn't been built into that system. Okay? So right away, you've got a clash of expectations that is based on mental models. From that come things like cognitive distortions. My health visit failed. I must have done something wrong. I failed my urine tox screen. The physician sent me a letter and told me that I was no longer accepted in their practice as a patient. What have I done wrong? I must not be a good enough patient. Okay? It makes me crazy when I read that. I get really frustrated by it. Cognitive distortions convince us, they are a filter, and they convince us that a course of action should be selected and acted upon. And they serve to reinforce very negative or positive structures in our own experience. They also lead us to make logical fallacies. Logical fallacies are based on errors of inductive or deductive reasoning that stem from errors in logical arguments. For instance, this is one of my favorites. Logical argument. You can go get your prescription filled in 30 days. You can't go at 29, right? You can't go at 28, even if there's a holiday or you've got to travel to Florida. You have to conform and adhere to the mental model that the law has built into our system that is regulating your daily life at the moment. Now, there is nothing in the world to support the fact that there is a better patient outcome or a better physician outcome if the patient fills at 30 days as opposed to 28. Except this thing out there in the news that's chirping at our shoulders about the deaths from overdoses. 5 years ago, 10 years ago, you know, your lives didn't change. What happened was something in your system changed. And it's creating a burden not only for you, but for pharmacists and physicians at the same time. It's not working for anybody very well. It also creates cognitive bias. Now, a cognitive bias is a thought processing error that gets codified not only in our own behavior, but in our logical rules that are applied in the local systems in which we operate, okay? We're going to talk about some of those. These cognitive errors are associated with different kinds of thinking patterns. System 1 survival includes pattern recognition, overconfidence, halo effect. We're going to talk about several of these, not all of these. System 2 errors are very rational biases, confirmation biases, authority bias. Physicians are a very, very important part of your daily life. Your care partners, the people who you depend on, are very important to you. What they think is very important to you. Small numbers fallacy has a lot to do with how we manage the information that's chirping on our shoulder and in research. Let's talk about something called Occam's razor. This is something that people are taught in health system schools. And people like me, when we're talking about counseling and rehabilitation, it's something that has to do with the laws of parsimony, okay, or parsimony, a scientific and philosophic heuristic that is interpreted as requiring that if there are a number of explanations for an observed phenomenon, the simplest explanation is preferred. Okay? Makes sense? Right? When you hear hoofbeats, think horses, not zebras. You're a zebra. You're not a horse. Maybe at one time you were, but you're chronic pain patients, and the law of parsimony does not apply to you. Okay? So as a cognitive filter, a heuristic, a rule of thumb for thinking about whether you're system 1 thinker or system 2, you know, you got a problem there. You've absolutely got a conflict in what happens to you when you interact with the healthcare system. Biases are systematic error. They introduce something called systematic error. They coded in the fact that I failed a drug test into my medical records. Now, I can't go anywhere and get a replacement physician. Because of shared medical records, I can't go to the ER, and if I go to 3 places to try to get my prescriptions filled, because 2 of them don't have enough to fill them, I have three pharmacies coded into the PDMP system, which in many states cannot make a correction, by the way, if the information gets put in there wrong. So a bias is any influence or action at any stage of a study that systematically distorts the findings. These biases operate in our daily lives. They are the mental models that we work with, and there are 3 in particular that affect the people in this room. This is an algorithm over here on the right, and of course part of the bias noise in the news that everybody's responding to is, well, I can't give you more than 30 days and I have to work you down under 90 days because the CDC guidelines say I have to do that. Well, that's not true. That's not what the CDC guidelines say. But there are biases that have developed now that are codified into practice. And there are 3 that are particularly important for us to understand: anchor bias, confirmation bias, and framing bias. We've all seen this. I know you've all seen it. If you're scrolling through Facebook, some of you can find it right now in Facebook or Twitter. Okay? Jeff Sessions says that marijuana is just as bad as heroin. And by God, he's going to allocate every resource in the country that DEA has to root out the scourge.
Sorry, I can say
You can own him. We'll talk to you after this is done. Okay? But you know, good old Jeff Sessions is a victim of his own learning. He is a victim of heuristics, logical fallacies, and biases. And the only way we get past that is if we have a conversation that addresses those things carefully. Okay? Everything you look for and everything you perceive has a way of proving whatever you believe. So if you want to find monsters in the closet, you're going to look for that data that tells you that. If you want to find monsters in the closet, you can be sure that you will adjust your behavior accordingly to avoid those monsters. Anchor bias. This is a picture capture from the fungal meningitis outbreak. 14,000 people were exposed to contaminated drugs, 21 clinics, 21 states, 75 clinics, 14,000 people, purchased from a compounding pharmacy in Framingham, Massachusetts, for the simple reason of cost. It was cheaper. Not that it was conforming, or that it was safe, or that it had been manufactured properly, but it was cheap and available. Anchor bias, focused on the wrong thing. Framing bias is something that we're dealing with right now. Those little crickets that are chirping on our shoulder, everybody's hearing the same message. You're hearing it, your practitioner physicians are hearing it, the ER personnel's hearing it, everybody's hearing the same message. The problem is that the messages get really truncated as they get framed because humans are efficient and the noise in the news is a system one process. So it's automatically going to reduce complexity in order to create heuristics that carry a message that everybody understands. That message will generally be perceived by the public as true, even though it is not true. Okay? So this is where I think patients have a great opportunity to help to reflect and move this conversation back as you understand what's going on with this messaging, that we begin as patient communities to reframe your experience, to teach you how to tell the stories so that your listeners can hear them and respond to them. And to arm you with the language that moves that learning. I believe that patients are powerful. Bandwagon effect. We're seeing this with every guideline, every state law. We have the CDC guidelines. They live among us. Now we have the VA guidelines. Who are affected by the VA guidelines in here? Anybody? The new VA guidelines? Okay. So, yeah, that's pretty interesting. So now we don't know exactly whose rights or guidelines prevail for these state hospitals that are located in states, whether they're state, they come under state, or they come under VA, or they come under insurance, or we're still sorting all of that out. But what we do know is that the bandwagon effect is operating pretty hard. If it was good enough for them, it's good enough for me. If this person who I respect and has power has made this change, then that must be something that I should be doing too. And that's what we're seeing in the world of politics right now. This is often also known as early adoption. The problem is there often is there's no information about it. So we're going to move to something called data. Now, the problem with data is that we've heard the words big data. You are a data point in here. As a room full of people, you are a larger group of data. But the problem with data is that we regress to the mean. We take the average of the human experience and we regress it to the mean. The problem is also that data does not include all of the people who are part of the discussion and affected by the issue. So if there are 100 people in here, 150, then what we've got is about 30 of you who statistically will be included in the research studies that we talk about. And nobody includes people with chronic pain for the most part. Okay? And this is what I believe is an opportunity for consumers. And that opportunity is moving us towards something called patient-centered research or community research. This is very important for you to get involved in. Nobody is capturing the patient experience. If we as a patient community don't do that, it won't be done. Say amen if you believe that. Okay? So we also have this thing called confidentiality. We may have to step past those reservations in order to get this done, but we have to do this. We have to find a way to tell this story so that we can be heard. Because if we don't, we are stuck with this idea, and that is the normalization of deviance. The normalization of deviance happens when biases, fallacies, and all of these mental models work together to create an institutional structure of policy, regulation, and resources. Okay? That is harmful. And it's harmful because it doesn't get tested. We don't test the data that is derived from deviance. If we believe that it is okay for us to be analyzed against a system of adherence or conformance, then the only thing we're measuring is the fact that we show up every 30 days for our pharmacy appointment. If we believe that the 90 MED dose is the appropriate indicator for whether or not our health care is being delivered effectively, then all we are measuring is the 90 MED dose, delivered in 30 daily increments and filled every 30 days. We are not measuring the patient. We are not measuring the patient's experience. That's a logical cognitive trap. We work in a system that looks like this. This does not measure your experience. This is what we need to be moving toward. This includes measures of how we are affected by the healthcare decisions that we make in our own communities. We're looking for outcomes, and we're looking for impact that are the result of not only the structures that are available to us, but the way they're organized in our community. We have to change our mental models and get involved in that process. This is kind of a characterization of a pain cycle. Depending on who you're talking to, you're either here or you're here. And it's based on research and data, but it does not reflect your experience. We need to change our mental models to a systems-based approach. Okay? We're not regressing to the mean, and you are not like your neighbor or the person sitting next to you. What happens to your health care matters to you. And it is a result of how you are interacting with the systems that you have available to you. And they are not like everybody else's. If we're looking at processes, these are all of the things that are involved in your health care. You as the patient, your health care provider, your community, the policymakers, and time. What happens over time? So here's another representation of complex adaptive systems and how they organize. And we want to talk about reorganizing this for consumers. So we take this very complex model and we remove it to community, disability, impairment, and individual. This is what we're measuring, or should be measuring. And it's more than a data point for MED or the days that you are involved. And we can talk about this later in the day if you want to, because I think it's worth talking about. But one of the things that we need to change, and I want to leave you kind of with this thought because we're reaching the end of our time together this morning. There are two ways of thinking in a system we need to be concerned about. One is transference of responsibility to you as the consumer. The other is managing the system of care and the partners that are available to you. There are two very different processes associated with that. We look for problems of human factors, reframing our understandings of how we're affected, and what we expect from the system in which we're operating. Obstacles, cognitive errors are shared errors. The way you tell your story affects what happens to you. So we want to really look at that in terms of the language that we use and the information that we convey and what that system has to offer back to us. Design errors. In Tennessee, we have hardly anything left in our rural communities. We don't have healthcare systems that are effective and functioning. We may have to go 150 miles to get to a physician. Now, in the current guidelines, if you go more than 50 miles, you're automatically red flagged. If you try to fill your physician's prescription more than 50 miles away, you're automatically red flagged. Okay? So we need to be challenging these notions about design of points of entry and access to health care. We need to be looking at impact and their influence. And finally, we need to reimagine the communities in which we're operating of care. Your voice is very important to this discussion. I cannot emphasize that enough. If we remain invisible in our communities, we got nothing. So we need to change that. We need to look at all the places that we measure our personal success and get them working with us and invested in our healthy outcomes. And finally, I want to leave you with a mental map here. This is healthcare right now. This is what we as consumers are dealing with. It is also what we as physicians and healthcare practitioners are dealing with. Okay? As you leave this planet, 1 in 5 of you will leave being impacted by this problem. It's a lifespan issue. We are all affected. If we're not affected today, we'll be affected in next month or next year. So I just want to leave you with this. It's not somebody else's problem. It's our problem to solve. Okay? Thank you.